Hello everyone, welcome to sqadia.com, and in this section we will talk about some other benign ovarian tumors. In this we will talk about serous and mucinous cystadenomas, dermoid cysts, fibromas, thecomas, how they all present and how they are treated, and what are the complications of these cystadenomas and dermoid cysts and thecomas. So first is serous cystadenoma. Serous cystadenoma is usually or generally benign. It's in 10% of cases, it's bilateral, so both kidney ovaries are involved in 10% of the cases. Risk of malignancy, it can be 5 to 10% borderline, and 20 to 25% it can be malignant. So mostly they are benign, but in about 25 to 20% of cases they can lead to malignancy. On gross appearance, usually serous cystadenomas present with multilocular with papillary component. When seen under the microscope, the serous cystadenomas present as low columnar epithelium with cilia present. So columnar type of epithelium is present. If you see in this microscopic picture or slide, you see all this is the columnar epithelium is present. So under the microscope, columnar epithelium with cilia. Cilia are hair-like projections. So columnar epithelium with cilia are present. The characteristic of serous cystadenoma is the presence of psammoma bodies. Psammoma bodies is the product of degeneration of papillary implants. So psammoma bodies are present in the serous cystadenoma. This serous cystadenoma is usually associated with fibrosis, when it is associated with fibrosis, it is known as cystadenofibroma. So when it is associated with fibrosis, it is cystadenofibroma. Cyst is the hollow structure, cystic, filled with fluid. Adeno is the term used for glands, and oma is tumor with fibrosis. So different. So this was basically about serous cystadenoma, generally benign, can become malignant in 25%. Psammoma body is the characteristic finding in the serous cystadenoma. Then mucinous cystadenoma. Mucinous cystadenoma have a tendency to become very huge mass. Here if you see, it's huge mass. So they can become huge. Round to ovoid with smooth capsule. Here smooth capsule with translucent whitish or bluish gray. Usually it's so here it can be big, round, smooth capsule. Very good picture here. You can see smooth capsule and usually translucent or bluish to whitish gray. Interior divided by septa. Here you can see the septa present, which divided into different loculi containing fluid. Epithelium, usually it's pale staining, secretory, and it has basal nuclei and goblet cell. And 5 to 10% usually are malignant. So mucinous cystadenomas Characteristic features are they can be huge. Usually they are smooth. Capsule is smooth, round, or ovoid. They have septa inside that gives rise to different loculi, and those loculi are filled with the fluid containing clear or viscid fluid, thick viscid fluid. The epithelium of this mucinous cyst adenoma is pale. It can be secretory with nucleus present at the base, and usually goblet cells are present. Then we have dermoid cyst. Again, very good picture. In the dermoid, you can see here, you can see the teeth. It's a very, very good picture. Dermoid cysts usually contain hair or teeth. Usually dermoid cyst again is bilateral in 15 to 20% of cases. When we see it on the gross appearance without microscope, you see it's a thick, opaque, whitish wall. Thick, opaque. Opaque is not transparent. Nothing can pass through it. It's thick and opaque. It has hair, bone, cartilage, and greasy, sebaceous material. So it's a very, very clear picture of hair, bone, greasy, sebaceous secretions are present in this. When seen under the microscope, all three layers are present: ectoderm, mesoderm, and endoderm. That's why we have all these structures, bone, cartilage. So the structures arising from all these three layers, they are present in the dermoid cyst: ectoderm, mesoderm, and the endoderm. Malignant changes occur in 1 to 3% of the cases, usually squamous type. Torsion, twisting or torsion of dermoid cyst is present in 15% of the cases, and the cystectomy is done usually a small amount of, when ovarian cystectomy is almost always possible, and if it's done, small amount of ovarian tissue left behind. Fibroma, most common benign solid neoplasm of the ovary is fibroma. So before we went over cystic tumors, now it's the solid tumors. And among the solids, fibroma is the most common solid tumor. It is approximately 5% of benign ovarian neoplasm and 20% of all solid tumors of the ovary. So it's 20% of all solid tumors. It is present in middle-aged women usually, and it is characterized by it is hard, firm, solid, and it resembles to myomas. Myomas are the muscle tumors. So myo is muscle, omas are the tumors, so muscle tumors. So because of the firmness, they resemble myomas, and usually misdiagnosed as fibroids, exophytic fibroids. Exophytic, which are fibroids present outside the uterus, or primary ovarian malignancy. Not hormonally active. Fibromas are not hormonally active. They do not produce any hormones. May be associated with ascites. Ascites is the presence of fluid in the abdominal cavity, or they may be associated with hydrothorax, which is the presence of fluid in the chest. So all this because of increased capillary permeability. Increased capillary permeability leads to increased presence of fluid in the abdomen and in the chest. Meigs syndrome, which is the combination of ovarian fibroma, ascites, and hydrothorax, is also present. And it's not very common, it's uncommon, but there is Meigs syndrome, which is the combination of all threes, and usually surgically removal is done. So fibromas are the most common solid tumors of the ovaries. Usually they are misdiagnosed as exophytic fibroid. Exophytic fibroids are the fibroids outside the uterus, and they can be confused with the ovarian malignancy. And Meigs syndrome is a syndrome in which fibroma, ovarian fibroma, ascites, and hydrothorax. Hydro is fluid, thorax is the chest. So all these together make a syndrome known as the Meigs syndrome. Then thecoma. Thecoma is solid fibromatous lesion that show varying degree of yellow or orange discoloration. So thecomas are yellowish or orange discoloration is present in this. It is usually unilateral, almost always confined to one ovary. So thecomas are not bilateral. Usually occur after 40 years, 65% thecomas occur after menopause. May be hormonally active, like fibromas were not hormonally active. So thecomas, they can be hormonally active and associated with estrogen or androgenic effect. Then we have luteinized thecomas and latex cell thecomas. Luteinized thecomas are usually present in younger age. They present with the peritonitis and ascites. Peritonitis is inflammation of the peritoneum, which is the covering of the abdominal organs, and ascites is the presence of fluid in the abdominal cavity. So luteinized thecoma and latex cell thecoma, in which we see usually the Reinke crystals are present. And then this thecoma is very rarely malignant. So this is the picture showing thecomas and the Reinke crystals are present. Now, clinical presentations usually asymptomatic, very accidentally they are discovered on ultrasound. Usually they have a chronic pattern of pain, increased since they are huge masses. So increase in the size of the abdomen is usually very common, along with abdominal or pelvic pain. Associated with anorexia, nausea, vomiting, urinary frequency. Again, urinary frequency is most likely due to pressure. Could be associated with amenorrhea, menstrual irregularities, virilization, and precocious puberty because of the association with different hormones. Then sometimes if complications occur like rupture or torsion, it leads to very serious pain and hemorrhage and should be treated as an emergency. Benign ovarian neoplasms usually are indistinguishable from malignant tumors, malignant counterparts, until further test or diagnosis are done or unless or otherwise proved clinically. So these are some clinical presentations of the benign ovarian tumors, which included, we covered cystadenomas, and then we covered some solid, which are fibromas and thecomas. Now, complications, torsion is here in this picture. If you see, torsion is twisting. So when twisting occurs, usually blood supply is blocked, there is necrosis, there is a death of the tissue, and this is associated with very severe pain. So torsion, usually there is inside the cyst, there is hemorrhage or bleeding, infection of the cyst, rupture, and usually pseudomyxoma peritoni is present, and then conversion of benign tumors to malignant tumors or malignancy can also occur. So these are some complications. So that was all about the cystadenomas, dermoid cysts, fibromas, thecomas, clinical presentations and complications. Thank you for watching sqadia.com.